Diana.
Well, I'll be the one to fail. You can remind me of the time. I wear many hats. I'm here representing the American Academy of Nursing, where we have identified nurses who have developed innovative models of care for which there are good clinical and financial outcome data. Some of them have teams led by nurse practitioners. I'd be happy to refer you to some of the stellar examples of nurses leading teams too. I would like to speak to the importance of this topic of culture change in organizations and the professions. I could probably talk all day about the culture change in nursing that is needed, but I'm going to focus mostly on the culture change in medicine and in healthcare organizations, and in society. I want to do that with 3 examples. The first one is that the White House Conference on Aging was held within the last couple weeks, and a journalist colleague of mine told me she was very disappointed that there was not one nurse on any of the panels. Now, this is after the John A. Hartford Foundation has invested millions of dollars over more than a decade to prepare exquisite nurse researchers, scholars, and clinicians to be leading changes in care of older adults. Not one nurse was at the table. The second example is an acute care nurse practitioner and has a DMP, and she is prepared in managing populations, and does an exquisite job of this. She is a national and international leader in her specialty. She is often the only nurse at the table that's writing standards of care and is developing best practices. She consults, she speaks, she's asked by the FDA to come and present. She works in an academic medical center, one of the leading academic medical centers in the country, part of an academic health system with a sister academic medical center in the same place. She leads quality improvement efforts for this patient population, and she's always interprofessional. She gets the pharmacists at the table, the social worker, obviously, the physicians, and others to the table. She teaches medical students, interns, and residents. She guides them in their quality improvement projects, and their projects win awards. She can get no appointment to the College of Medicine. She has been trying for over 5 years for an appointment and was first told, you don't have a doctorate. She got the doctorate, and now she's told, well, we can't give you that appointment. There is a physician at the sister hospital who is the department chair in this specialty who came to her and said, I'm now going to be in charge of the quality improvement efforts, and I'm going to focus in on medication errors, and we don't need nursing at the table. I'll have pharmacy at the table, and pharmacy has to be at the table. But this nurse practitioner knew the data and said that, well, 1/3 of the errors are by nurses. You better have nursing at the table. And she said, no, we don't need you. And I will point out that she does have a fabulous physician mentor there within the institution that really helps her to navigate as she tries with this system. But yesterday, this nurse said to me, physicians are the center of the universe in this institution. They are being appointed and brought in to head all programs. She said, I'm not given the opportunity to have the title for the work that I'm doing in this institution. The third example that I want to share with you is in another part of the country in a very large health system. A nurse in one of the hospitals in that system has a master's degree. She doesn't have a doctorate, but she's also a very thoughtful, smart, expert nurse. She developed a model of care for patients who are high utilizers of the emergency department and have high rates of hospital readmissions. And she has worked very hard to reduce and has substantially reduced emergency department use and hospital readmissions in this population that is largely dual eligibles, Medicaid recipients, and people with substantial psychosocial problems, substance abuse, et cetera. Of course, this has resulted in financial savings for the institution. And when these became known to the institution, her superiors got bonuses, she got nothing, and was told she had to be at a VP level to get in the bonus program. She was also told she was not allowed to publish anything about her work, and she was told she needed to sign away all intellectual property rights to anything that she was developing. She came to the attention of the president of this health system, who is a physician, and understood the importance of what she was doing. And he said to her, I want you to roll this out throughout the health system. She said, I'd be happy to do that. I'd like a system level title so I have that authority, and I'd like a pay increase doing this work, and I would like a title that will put me in the bonus program. And he said, well, we don't have the money at the system level to create a position for you, even though he had been creating positions for physicians to head up various programs at the system level. And we're not going to give you a title change, we're not going to give you a bonus, and you're not even getting a pay raise. And I think we'll put a physician in charge of your model. So these are some of the challenges that nurses are experiencing across the country. It's not happening everywhere. There are places that do embrace nurses as leaders in healthcare and are tapping into their expertise, but I'm hearing too often now, and that's why I wanted to share these examples, that there's almost a backlash in some places. This idea that nurses cannot lead in these institutions, that we have to have physicians to lead these initiatives, and I think we have to challenge that, and I don't think it will be easy to do. I do have a couple recommendations for doing that, but I'm running out of time, so I'll save that for the discussion period. Thank you.